good afternoon, everyone. Thank you so much for staying to attend UWIHARP's S-Files discussion. This week, we are focusing on cervical health, and this is the second S-Files discussion that we're having for the semester. And a little bit about UWIHARP, for those of you who may not know. We are the HIV program on campus, but we also branch out into broader sexual and reproductive health concerns. We like to think that we seek a positive response to how we talk about sex and sexuality and sexual wellness. So what we focus also on building persons' knowledge about their own sexual and reproductive health here on the university and in the wider Caribbean. And our primary focus is the development of sexual health literacy so that you know what's going on with your body. We find very often that people don't understand what's happening, so they're not able to understand what changes are happening with their bodies. So we do this through interdisciplinary research as well as sexual health capacity building, which is teaching and training, and also sexual reproductive health and rights. And we spoke about S-Files would come under advocacy as well. As I mentioned, we also are developing a course where we will be doing peer education program to go out into the community on campus and off campus to do sexual health education and outreach. We also distribute condoms free of cost from our office. We're in the process of procuring those right now. We support STI testing on campus in collaboration with the Student Health Clinic, as well as the Ministry of Health and Wellness, and it's free of cost to all students. And this is testing. Dr. Whitby will talk about the importance of getting these tests. This is chlamydia, syphilis, gonorrhea, and HIV. And we also do sexual health research. And this is action-oriented research where it will inform policies. Also, a little just to inform you that we will be facilitating breast screening next week on campus through the ministry, through the Breast Cancer Society. They're coming with the mobile unit on Thursday the 31st. It's Halloween Day, you can't forget that. It's going to be on campus between 10 to 2, and there's a cost of $20, but the first 20 persons will be free. So those flyers are going to go out early next week. So you want to make sure that you get in early to get your screening done. And it's open to staff and students. All right, just one or two words about the S-Files project. What we're trying to do is create a safe space here to discuss a wide range of sexual health topics. And coming from HIV, we found that the language around sex and sexuality was very often demonized. Now, we found that, yes, you can talk about risks and you can talk about prevention without having such harsh language. So we try to use more sex-positive language and couched in responsibilities and respectability. So a couple of things to be mindful of in these UWIHARP discussions. You may hear a range of views that you may disagree with. Please be respectful of other views, although they may differ from yours. We cannot guarantee confidentiality in a group. Be cautious about what personal information you disclose about yourself and others. It is safer to talk in general terms. Any of us in the group might be living with HIV or another STI, with or without our knowledge or status. Additionally, anyone in the group could be homosexual or have had a pregnancy termination or abortion, a miscarriage, or experienced infertility. Please be conscious in the way we discuss these sensitive topics, regardless of religious or moral beliefs, taking care to talk in ways that do not discriminate or alienate the others in the room. And be mindful of UWIHARP's guiding principles: first, do no harm. And we ask that you don't take any photographs. We are doing it mainly for documentary purposes, and because it was also suggested that we just film the facilitators as a way of outreaching and maybe uploading it to a YouTube channel. Welcome, ladies. I just want to point out the other S-File talks we'll be having. They'll be going on until the 29th of November, every Friday, the same time, the same room, unless they move us. We had menopause last week. We have cervical health this week. We have uterine fibroids next week. We have midwifery and doula. And then we have pre and post exposure prophylaxis. And then we have street harassment, and we will be commemorating 16 days of activism. We'll talk more about that later. And we also have, the last one is going to be on vaginal steaming. So I expect that was going to be quite exciting. Right, so we finally get here. Cervical health, and just broadly, we are looking at basically building your knowledge on what the basics of cervical health, things to look for, things about changes, and also to talk about how pervasive it is among Caribbean women. I think that's what was missing last night. To outline possible prevention strategies, causes as well, symptoms, and to advise on medical and non-medical treatment for cervical cancer. And we have Dr. Whitby-Best, who has been really good to us and will be delivering today's talk. And I'll just read her bio. She graduated from the Faculty of Pure and Applied Sciences at UWI Mona in 2000, and the Faculty of Medical Sciences, UWI Mona, in 2005. Following the completion of her internship at the QEH hospital here, she joined the Department of Otolaryngology and then subsequently joined the Family Medicine Doctor of Medicine program, which she completed in 2014. She's presently the medical officer and head of the Student Health Clinic, UWI Cave Hill Campus, and a part-time tutor and examiner with the Faculty of Medical Sciences. Dr. Whitby-Best is the Honorary Secretary of the Caribbean College of Family Physicians, and her interests focuses on mental health and primary care. If you can join me in welcoming Dr. Whitby-Best.
Well, thanks for coming out, everyone. I've already been introduced, so I'll just get right into it. All right, so basically today I thought it was important to talk about cervical health because I found in practice that there was some gaps in knowledge that persons would have with regards to cervical health. Why do we do pap smears, HPV virus, and so on. So today I want to spend some time first to describe what the cervix is, outline the functions that it has. We'll discuss some things that could go wrong with it, but mainly to focus on screening for the worst thing that could go wrong, which is cancer. Discuss that screening in details, which is via pap smear, and also to talk about the human papilloma virus and how it affects the cervix, and how do we test and prevent that virus. So, the cervix. Yeah, the light is working. So this is the cervix. It's actually the narrow passage forming the lower end of the uterus, right here. And it has quite a bit of functions. It's the lowest region of the uterus, and it attaches the uterus to the vagina. It provides a passage between the vaginal cavity and the uterine cavity, uterine meaning uterus. And it's only about 4 centimeters long. And when it projects into the vagina, it's about 2 centimeters in length. The opening of the cervix into the vagina, we call that the external os. And the length of the cervix, we call it the endocervical canal. And then the opening, which is the top part that opens into your womb or your uterus, is called the internal os. And here you can see the picture. This is the uterus, or the cavity of the uterus. And right at the top of the cervix would be the internal os. We call this a cervical canal, and this is the external os. Now, the canal of the cervix transports sperm into the uterine cavity. It also allows the escape of blood from your uterus during your menstruation, and it also supplies mucus to the female reproductive tract. And during childbirth, the canal is greatly stretched. However, during pregnancy, the cervix is the only part of the uterus that does not expand to house the developing baby. Now, the cervix produces mucus, and persons I do see quite a few persons always having vaginal discharge. That's one of the most common complaints that most persons in primary care will tell you that they get. And not all discharge is abnormal. The cervix produces mucus in the proliferative phase. This is the first part of the uterine phase of menstruation, right? And then that discharge changes over time. It gets profuse and watery at the end of your ovulation. And then the secretory phase, which is the third phase of the uterine part of your menstruation, it becomes scant, thick, and opaque. And for some persons who are looking at getting pregnant and checking on their fertility, might actually try to use their discharge to determine when they're fertile and less fertile. Okay? And as you can see here, less fertile after the menses, there's a thick mucus. More fertile, usually after the menses too, the opening of the cervix gets very small. It gets to about 1 millimeter. But then when you're more fertile, it can open up to as much as 6 millimeters, right? And the discharge can get thicker and watery. And then when you're less fertile, it can close back up and give back that thick mucus. Okay. So again, this is just showing the same things I was saying as before in terms of the mucus production. And as you can, on this column here is showing the fertile cervical discharge, right? It can be slippery, clear, and stretchy. Okay, I've had persons describe to me that sometimes it gets stretchy. Okay, and that's usually during the fertile phase. Now, the cervix also transmits sperm at or near the time of ovulation and interfere with entry at other times. And that makes sense, right? Right, because when you ovulate, it would facilitate then sperm being able to get to the egg to fertilize the egg. It protects the sperm from hostile environment of the vagina and from being phagocytized, which is being destroyed. And it provides energy requirements for the sperm, and it serves as a reservoir for the sperm. So it actually does what it needs to do to ensure that you get pregnant, right? Now, of course, like any other part of your body, things can go wrong, okay? And some of the things that you might find going wrong with the cervix are ectropium. And this is actually where on the outer part of the cervix, we call the cells on the outer part the hard cells, and the cells on the inner part soft cells. And sometimes they meet. The soft cells is found on the outside, and it can give you this red appearance, okay? May not have any symptoms, may be seen when you get a pap smear and the doctor looks, may have bleeding during the period, may have bleeding after intercourse, doesn't necessarily need treatment. However, if there are problems associated with it, then yes, it can be treated via colposcopy when you see the gynecologist, okay? They can try to cauterize the tissue. You can also get cysts, and you're not seeing it very clear here, right? Sometimes you have these little crypts in the cervix, like these little indentations, and they can trap mucus, and they can give you these cysts. May not have any symptoms. Again, same thing, you can have bleeding after intercourse and so on. Doesn't necessarily need to be treated. May not necessarily cause any serious long-term problems. You can also get polyps, which is a benign tumor found, can be inside or outside the cervix. There is a thought that all polyps should be removed because there are some rare forms of cervical cancer that can actually present as a polyp, right? So it's supposed to be benign, but just in case, it's recommended that all polyps should be removed so that the pathologist can look at it and make sure it's not a rare form of cancer. And then, something we see commonly, cervicitis, mostly caused by infection with chlamydia or gonorrhea. And it can create a very, sometimes, odorous discharge, very copious, watery, discolored. And of course, that would need treatment with the relevant antibiotics. Now, I'm not going to spend too much time on that. I think at some other point we'll have to do a talk on STDs, right? But most commonly, cervicitis, chlamydia, and gonorrhea infection. And in our setting, chlamydia is more common than gonorrhea. And then we have the real serious things that could go wrong, malignancy or cancer. You can get what we call pre-malignant changes, which from a normal cervix, you can get low-grade or high-grade changes that can lead to cancer, or you can get cervical cancer, and usually that's what it looks like, a white, fleshy kind of appearance. So that's why we want to evaluate and screen the cervix. What we're really screening for is cervical cancer. Now, there are several screening guidelines available based on research from different countries. This, what I have here, is actually what the USA does. The USA and Canada tend to follow this. And I thought it was important to put the different screening recommendations, because you always hear patients say, but I'm supposed to get a screen every year, I'm supposed to get a screen every year, but it's not really so. As you can see here, women younger than 21 years, no screening. I should not see a 16-year-old who had a pap smear. I shouldn't see a result for a 16-year-old who had a pap smear. And then the other extreme, women, you know, they said older than 65, no screening necessary. I've seen pap smear done on an 80-year-old with no symptoms whatsoever. So what guidelines are we following, right? So in the USA, they said 21 years, no screening, regardless of when sexual activity began. 21 to 29 years, just the pap smear only every 3 years. 30 to 65, pap smear with HPV testing at the same time every 5 years, or pap smear only every 3 years. And they said screening by just doing the HPV alone is not necessary. Women older than 65, no screening necessary. Adequate, if adequate, negative results before. If all our results were normal before, at 65, you can just stop, right? But if she had a history of any of these pre-cancer changes or cancer itself, right, then you would want to continue screening for at least 20 years after the diagnosis, okay? And women who have had a total hysterectomy, that means the whole uterus was removed, including the cervix, no screening is necessary. And women who were vaccinated against HPV, it's still recommended that they follow the guidelines. Now, note most of this is if you've had normal results. If there are abnormalities, then it's not going to follow the usual pattern, depending on what the abnormalities are. So what do we do in Barbados? So Barbados does have screening recommendation, which was given out by the Ministry of Health in 2013. And it's similar to the US one, but just slightly different. They do say, yes, under 21, no screening, but 21 to 49, while the USA said 21 to 29. Barbados, 21 to 49, screen every 3 years, provided the last pap smear was normal. 50 to 65, screen every 5 years. And that is if they have had no abnormal smears for the previous 9 years, at least one pap smear every 3 years in the previous 9 years. And if above not met, then you screen every 3 years. And greater than 65, no smear necessary. Now, the UK did theirs a little differently. And they actually follow almost the same thing as Australia. They said don't screen before 25. So under 25, you don't screen. First invitation is at age 25. Then every 3 years up to age 49. Then every 5 years up to age 64. After age 65, only screen those who have not been screened since age 50, or have had recent abnormal tests. So most persons are saying to stop screening at 65, right? What does cervical screening entails, or pap smear? And for patients I've had who have never had a pap smear, doesn't know what the procedure entails, I like to explain to them and show them the instrument. So we see an instrument here. Look familiar for some of us? Look familiar? Yeah? Invented by a man. In the 1800s, Dr. Sims decided to experiment on slaves, black women, right? And came up with a device. It didn't look as good as this, but he came up with a device to better be able to see inside the woman's vaginal canal to see what is happening, right? Because in those days, they used to examine women with just their hands. They didn't used to look. They used to just put their hand under the skirt, because they didn't want to. It was something about men looking under women, then it was a problem, right? And they realized that, look, you can't properly treat the people like that. You got to see what is happening, okay? So he came up with a device, and over the years, it has been tweaked, but no one has been able to replace it. This is actually a couscous. We call this a couscous. In the 1940s, that doctor actually came up with this latest design. There have been attempts I've seen in literature where persons were trying to come up with an inflatable speculum, which should be more comfortable and avoid the pinching that you would get from it. But for some reason, it's fizzled out since the early 2000s, and you haven't heard anything else about it. Something about the patent, some problems with the patent or something. But persons have tried to replace the speculum and have not been successful. And in reality, it does do what it needs to do. We can't deny that. It might not be the most comfortable, and nowadays we tend to use a lot more of the disposable, the plastic ones, which will not be as cold and tend to be a little more tolerable, right, as opposed to the metal ones that would have been used not too long ago. So a pap smear is a test carried out on a sample of cells from the cervix to check for abnormalities that might be indicative of cervical cancer. And basically the procedure is the woman is lying on her back. Usually you might do a vaginal exam first to just check everything, make sure there are no abnormalities that you can feel. Sometimes you want to feel where the opening, the cervix open is, because it's not the same in everybody, right? And that will guide you when you put the speculum in where to angle it. So the speculum is then inserted into the vagina, it's opened, and then there is a screw that will lock it in place so that it keeps the cervix right there in the center so you can see what you're doing. And then a brush is used to then twirl several times to get as much cells as possible from the cervix. It's put nowadays mostly in a liquid base medium, which is then sent to the lab. And then the speculum is removed. It takes a few minutes. Not the most comfortable, but it's tolerable, right? Now, the human papillomavirus is really a group of more than 100 DNA viruses that infect human epithelial cells. And of that over 100, it's only about 40 can cause genital disease. And only about 50 that are the high-risk types, which are more likely to cause cancers. HPV infection is the sole cause of cervical cancer. Most cervical cancers are going to be due to HPV. And HPV is divided into categories. We always talk about low risk and high risk. The low risk ones tend to cause things like genital warts, while the high risk ones are the ones that give you the precancer cells, low and high grade cervical intraepithelial lesions, and lower genital tract cancers. And a person can actually be infected with multiple types of HPV. It don't mean you're just going to get one. You can get 10 or 5 or 2 out of the 100 plus, right? And cervical cancer remains the third most common cancer in women worldwide. Now, HPV is a sexually transmitted infection, and it is one of the most common sexually transmitted infections in women. Up to 79% of sexually infected women will, well, it should be sexually active women, sorry, will acquire a genital HPV infection during their lifetime. That's almost everybody, that's almost 80% will get an HPV infection during their lifetime. And the infection is usually transient and asymptomatic, meaning they wouldn't have symptoms, they wouldn't know they had it. It's transmitted through contact with infected genital skin or mucosa. So condoms are not noted to be 100% effective in preventing HPV infection. Genital warts in itself are actually highly infectious, and up to 65% of those persons who get genital warts will actually show symptoms of that. Oral infection is rare, so you can actually get oral cancers from HPV also. And perinatal, which is in pregnancy, transmission is also rare. And what happens is it's not transmitted from mother to baby in the belly. It's usually during delivery that it can be transmitted to baby, and the baby can end up with a condition called papillomatosis of the larynx in the throat. And I've actually seen, I worked in ENT, as you said, for 3 years. And I remember in Jamaica seeing a teenager that's how he got his papules, and every now and then he has to get a lot of surgeries to remove them because there can be an airway issue. Receptive anal intercourse is associated with intra and perianal warts, but not always. Cervical and anal infections often coexist in persons with a history of anal intercourse. So up to 90% of those who get HPV will clear the infection on their own. Right? Which is why sometimes persons don't know they even had it. Within 2 years, you might just clear it on your own. In women, 30% genital warts spontaneously regress within 4 months. And sometimes when persons come with genital warts, I tell them, well, if you're willing to just wait and see, it might just go away. Sometimes it just go away on its own, but you have to be patient. Those who fail to clear infection are at risk of progression to malignancy, and that's usually if you have the high-risk HPV infection. So as you see here, a normal cervix gets infected. It's a HPV-infected cervix. You might just clear it and go back to being normal. Or there can be progression to the precancer cells, which can even regress and you can even go back to being normal. Or you can get invasion, and that's how cancer then comes about. Now, the peak prevalence of HPV infection in women tends to occur in the early 20s. And after such, it tends to decline. As you get older, the prevalence decline. And there's another peak that they know, but it's not as prominent as in the 20s in postmenopausal women, and this is just in some areas of the world. And the interval between infection and diagnosis of cancer can be anywhere from 10 to 20 years. So you might have abnormal cells in your 20s, but you might not actually get cancer till in your 40s. Other rarer HPV-induced cancers, so there are other areas that HPV can cause cancer: the vagina, vulva, anus, and the penis can all get cancer from HPV infection. And as I said before, in the mouth, oral cancers too, and respiratory papillomatosis, which is what I was telling you about the child, which during the birth, through the canal, mommy's birth canal, they got the HPV transmitted and they end up with papillomas on their larynx, okay? So the types of HPV, because remember I said there are over 100 subtypes, and we have the low risk and we have the high risk. So in all HPV-related cancers, HPV DNA integration in the host cell genome sets the stage for malignancy. And sometimes you get these oncoproteins E6, E7, because in some pap smear results, when we check for HPV, the pathologist might tell us that there's E6 and E7. These are usually an indicator that you need to keep a close watch on this person, or maybe even consider further screening, right? Because they're generated in which they can then turn and degrade the host tumor suppressor genes and then open up the door for cancer to occur. So as you can see here, I have HPV 16, and you'll hear about 16 and 18 quite a lot. These are considered high risk. And they're linked to, again, cervical cancers, some oropharyngeal cancers. And then you have some lower risk ones, but they can still cause cancer. And then we have 6 and 11, which is mostly linked to like the genital warts and so on. So benign genital lesions and the respiratory papillomatosis, right? And 13 and 32, which can cause oral epithelial hyperplasia, but not necessarily cancer. So it's always good to know what is happening in your area or your region. And thankfully, there was a study done in Barbados that gave us some information on what is happening with HPV in our setting. And this was a study done by Joan Ward from the Faculty of Medical Sciences here at Cave Hill. And what she wanted to do was to provide a baseline HPV genome distribution, genotype distribution among women in Barbados before the HPV immunization was introduced. And they looked at specimens, pap smear specimens that were collected from over 400 women between the age of 18 to 65. And they found that there was HPV in 33% of those women. And of that 33%, 70% of those were high-risk HPV. And the persons with the highest level of infection were aged 21 to 25, right? Pretty young, okay? And this here is showing the number of candidates screened by age for the HPV study, all right? So how does that compare with the rest of the world? So in looking at the different types, as you can see here, the highest is 45, HPV 45, while in the world, the highest that is usually found for cervical cancer is 16. And you'll see eventually why this is important to know what HPV subtype you have in your population. Our second highest is 16, and then our third highest is 52. And according to worldwide figures, 16, 18, 45, 31, 33. So not even 52 is in it. Okay? Now there was another study that was done in St. Vincent and St. Kitts. And they compared their numbers to worldwide figures. And in the orange is St. Kitts, and in the purple is St. Vincent and the Grenadines, and red is the world. And as you can see here, the highest for St. Kitts is 52, right? And the highest for St. Vincent is the 45. So not even the 16 and 18, which is found to be the highest number worldwide in other regions. So how do we test for HPV? It's detected through a polymerase chain testing or DNA testing. Testing for low risk that do not cause cervical cancer is of no clinical benefits. So for anyone who present with like a genital wart, I'm not going to check for HPV. It's not of any benefit. All right, it's not going to change how we manage, and it's probably not going to change the behavior the person has, their sexual behavior either. Anal pap test has been proposed as a screening tool in men, particularly men with HIV infection and men who have sex with men. The problem with doing the anal pap, well, we don't call it pap, but the anal smear, is that the cytology, when they do it, it might underestimate the degree of the high-grade neoplasm or the cancer. So once there's any abnormal findings at all on an anal smear, then they need to be referred for more screening and investigation, okay? Because it might be missed on the initial smear that it's actually a malignancy. The risk factors for HPV infection in women tend to be younger age, right? The lifetime number of sex partners, they say if you have more than 3 sex partners in a lifetime, that increases your risk for HPV. Early age of first sexual intercourse, They said if you tend to have started having intercourse less than 16 years, then your risk is higher. Male partner sexual behavior, again, we say it's sexually transmitted. So if you have a male partner who had many partners, then the risk is higher for you as the recipient, as his present partner. Smoking is known to be linked to HPV infection. They think it's has something to do with smoking causing your immunity in your body to decrease. Oral contraceptive use, mainly because of sexual behavior. Persons, I guess, would think if they can't get pregnant, then, you know, they're on contraceptives to decrease pregnancy. I guess then the risk would be, they're not worried about pregnancy, so then their number of partners might be increased because of that. Uncircumcised male, there's actually in South Africa where they found that circumcised male tend to have less penile cancers and all the cancers that are related to HPV, and not only HPV, also for herpes, that they tend to have less herpes infection, the uncircumcised male. And for men, again, young age, lifetime number of sex partners being uncircumcised, and if they have a sexual partner who has precancer changes due to HPV. Now, why are we screening for HPV? Why do we care about cervical cancer? In reality, in the developed world, in America, England, and so on, it's not really a major problem anymore. And I will say here, Australia is on track to eradicating cervical cancer, meaning they're on track to getting less than 4 cases per 100,000 persons, right? Why? Because they've instituted a screening program where they actually start screening at 25, and they screen every 5 years with HPV testing until age 70. And they have also instituted a vaccination program. So they've been doing pretty well and not getting many cases of cervical cancer, and they're on stream. They're hoping within 20 years to actually almost eradicate cervical cancer. And Australia is a big country, so that's significant. So cervical cancer in our setting, this is from PAHO, and this is actually Barbados figures. And I'm not seeing it well there. But in terms of cancer death for women, breast cancer is leading, then colorectal cancer, and the third one is cervical cancer. And then this table was actually looking at deaths caused by different types of cancers in different Caribbean countries in males and female. And here for Barbados, cervical cancer is at number 3, but it is number 1 in Suriname, and number 2 for Trinidad, St. Vincent, St. Lucia, St. Kitts, Jamaica, Grenada, Dominica, and so forth. It's number 4 for Antigua. So it still is a significant problem in our setting in the developing countries. And that's why we keep talking about it and talking about HPV and prevention of HPV. The Center for Disease Control and Prevention's Advisory Committee on Immunization Practices recommends routine HPV vaccination of girls aged 11 to 12 years with a catch-up vaccination for those at 13 to 26 years. So far, the vaccines seem to be safe, with most common adverse effects being just reactions at the injection site. They have had a couple of persons who may have fainted when they got the vaccine, so they advise that you make persons sit or lie down when they get in the vaccine and let them stay in that position for 15 minutes after. And some persons would complain of nausea and syncope. After vaccination, it's important that persons still get screened because the vaccines do not cover all. They do not cover all types of HPV, and also the vaccine will not necessarily alter the course of a pre-existing infection. So if it's already there, the vaccine may not alter it. Okay? So you can start the vaccine as early as age 9, right? Males are also included in being vaccinated from 13 to 21 years if they haven't been vaccinated previously adequately before. vaccination is also recommended through age 26 for persons who are homosexual, bisexual, and men who have sex with men, transgender persons, and for immunocompromised persons, including those with HIV infection who have not adequately been vaccinated previously. And ideally, an adolescent should be vaccinated before exposure to HPV. So you want to vaccinate before persons become sexually active. However, people who have already been infected with one or more HPV types can still get protection from other types. So you can still get the vaccine because you might have been infected with one type and the vaccine is protecting against another type. So at least you'll still get protection from that, right? So key recommendations, you want to limit the number of lifetime sex partners, if this in terms of prevention, to stop smoking if you smoke, delaying the age of first intercourse, to get vaccination with the HPV vaccine, consistently using condoms, but remember condoms only offer partial coverage, about up to 70% in terms of protecting from HPV and also from herpes. I mention that all the time because it's just by close contact. And male circumcision reduces the risk of HPV infection in men by 35%. Now, I just want to say something on the vaccine. Presently, the vaccines that are available, there is Cervavax, which is the vaccine that protects against two subtypes, the 16 and the 18. And then they created a quadrivalent, which protects against 6, 11, which are low risk but more cause genital warts, and 16 and 18, right? And that one is called Gardasil. Now there's a Gardasil 9, which covers 9 different subtypes, including the 45, which if you remember from my bar charts and so on, that in Barbados, that found to be the highest subtype, and also in St. Vincent and so on. So I know that within the program here, where they're vaccinating the children, they were using the Gardasil. So then an appeal is being made for them to use Gardasil 9 instead. Now there's some cross reactivity because they do say that the subtype 45 genetically is similar to the 18. So they're thinking if you use the Gardasil, it can still protect against the 45. However, I guess time will tell if that is so or not. But ideally, in looking at the benefits and what we have information, we have data, which sometimes we don't have. Then maybe we should try to use the data and protect our population better and give them the Gardasil 9. All right, so those are my references, and if there are any questions, we're now open to taking questions.
Thank Dr. Whitby-Best for giving up her time and sharing with us today. And see you hopefully next week.